Welcome to Med1 Pager. My name is Benjamin. Today I'm going to talk about another important emergency, and this is diabetic ketoacidosis. So diabetic ketoacidosis is going to be basically defined by three parameters. This is going to be hyperglycemia. Sometimes you have your glycemic DKA, and we shall explain that one because it's a special case where we don't have hyperglycemia and we have normal glucose levels. Ketosis, as well as metabolic acidosis. So hyperglycemia is going to be defined as a glucose level that is greater than 11 millimoles per liter, or that is 200 milligrams per deciliter. And when we have the normal glucose, that is going to be a euglycemic DKA, and this is when we have ketosis and metabolic acidosis also occurring. So ketosis is when we have beta-hydroxybutyrate that is greater than 3 millimoles, or when we have a positive urine dipstick for ketones. The metabolic acidosis is when the pH of the blood is less than 7.3, when we have a bicarbonate less than 15, and an increased anion gap. So DKA is going to cause an anion gap metabolic acidosis. So what happens is that when we have insulin deficiency, counterregulatory hormones are going to be high, or if we have increased counterregulatory hormones like glucagon, hormones like cortisol, these are going to cause a number of things. One of them is lipolysis, the first pathway. When we have lipolysis, we're going to have formation of free fatty acids from lipids. And these free fatty acids are converted into ketones in the liver, and these are what cause the acidosis. Then we have gluconeogenesis, where we form glucose from other sources other than glycogen. And we have hyperglycemia setting in. Then when we have this hyperglycemia, the kidney tries to excrete this glucose, but as it excretes glucose, it's going to require a large amount of water, a large amount of urine formation to push this out. And then we end up with what we call an osmotic diuresis. And as we push out this water, it's going to go with electrolytes, and the mostly affected electrolyte is going to be potassium, because as you lose potassium, as you lose the water, you are losing potassium. And also, because we are having an acidotic state, we have increased hydrogen ions within the cells. The cells are going to try to overall compensate for the increased positive charge within the cell. So they'll push out the potassium. And remember, the cells are mostly where the potassium is. So initially you may have a hyperkalemia in this patient, but as the losses go on, the potassium may normalize or even go low. But the normalization is because the potassium is being pushed out of the cells. So when you look at the whole body, we are having less and less potassium within the body. So we have the triggers, and triggers of this is going to be infection. Infections are going to cause stress and lead to increase in hormones like cortisol and other counter insulin hormones. And sometimes we have insulin emission, whereby someone forgets to take their dose and they will come in with this DKA. Then someone may have a new onset of type 1 diabetes mellitus, and most of the times this can be actually the first presentation. Someone comes in with in the diabetic coma, and probably you don't know what's going on, only to discover when you do the further investigations that they have type 1 diabetes mellitus. Sometimes it can be myocardial infarction. This is going to cause stress, and when it causes stress, we are having counter-regulatory hormones that can increase this production of glucose and everything else. Trauma can also be a cause. Surgery. We can have pancreatitis. The pancreas is responsible for formation of insulin. So if it's destroyed in pancreatitis, we can have this insulin deficiency, and the resultant pathways will continue. Then we can have steroid use, SGLT2 inhibitors, and these ones are the ones that are mostly going to cause the euglycemic DKA. So these SGLT inhibitors are mostly used in patients with type 2 diabetes. But what happens is that they go on reducing the amount, they increase the excretion of glucose by the kidney and the urine. So when you decrease this glucose, the amount of insulin in the body is going to fall. When the amount of insulin is going to fall because the glucose is low, the body is going to have increased counter-regulatory hormones and ends up starting a ketosis. Sometimes even pregnancy can do this, as well as starvation. And in starvation is the same thing. You're having insulin low, and when insulin goes low, you're going to have the other hormones, glucagon, going up, lipolysis and gluconeogenesis are going to take place, and then someone ends up with a DKA. So the clinical features, we're going to have polyuria, that is increased urination due to the osmotic diuresis, polydipsia because you're doing a lot of urine, you feel like thirsty a lot, vomiting, abdominal pain, cool breathing, anacetone breath, dehydration, and altered mentation, as well as coma. So when you look at the euglycemic DKA, this is when we have a glucose less than 13.9 millimoles or less than 250 milligrams. So you can see this one is slightly above the upper limit, but it is not that much. So what happens is that when we have SGLT2 inhibitors, when someone is pregnant or someone is fasting, or they're on low carb diets, or they miss their insulin, but also taking very little glucose, they cannot go into hyperglycemia. What happens is that they will have production of ketones as a substitute to provide fuel for the brain, and that is going to lead to the DKA. So the diagnosis is when we have ketosis, acidosis, plus an anion gap. So when you have ketosis, acidosis, and an anion gap, despite normal glucose, you want to think about euglycemic DKA. And the treatment is going to be the same as DKA, but as we shall see, for this case, you want to give dextrose early. And you want to continue insulin as well as stop the SGLT2 inhibitors. So the diagnosis and investigations, you want to do the essential tests. Are going to include the blood glucose, the serum ketones, that is the beta hydroxybutyrate. That's the best ketone you check for. If it's greater than 3 millimoles, then we have that. I want to do arterial blood gases or venous blood gases for the pH and the bicarbonate. Remember, I want a bicarbonate less than 15 for DKA. Run check for electrolytes, that's sodium, potassium, and chloride, urea and creatinine to check for kidney function, CBC, CRP, and cultures if we suspect that someone has an infection. Urine ketones have also been used as a backup method where we can use the urine dipstick. Then you have the corrected sodium. So when someone has hyperglycemia, most of the time, we have a dilutional hyponatremia because the hyperglycemia is going to pull water into the bloodstream, and we have a lot of water diluting the sodium in the bloodstream. So what we do is that we do a corrected sodium, and that means the sodium that we measure, we're going to add 2 millimoles to it. And for every 5.5 millimoles above. So when we look at the anion gap is going to be got by the sodium minus the chloride and bicarbonate. So you will see that as the bicarbonate goes low, this anion gap is going to increase. As the bicarbonate comes back up during our management, we are improving on the ketosis and everything else. This anion gap is going to be narrowing all the time. So it is going to be one of the ways that we monitor improvement during the management of DKA. Then we can look at the classification. We have the severity. We can say the mild to the moderate and the severe DKA. So when the pH is between 7.2 to 7.3, that's a mild. And the bicarbonate is between 10 and 15, that's also mild. As well as ketones +1. And mentation, most of the time they're alert. When we have moderate DKA, the pH is between 7.1 to 7.2, bicarbonate is between 5 and 10, and then ketones are also higher than mild. That's a +2 on a dipstick, and they are starting to become drowsy. Then when it is severe, the pH is less than 7.1, the bicarbonate is less than 5, and they have very, very many ketones, and they're going to have stupor or coma. And the management is going to be with the 4 pillars, and these are the 4 pillars of management of DKA. That is fluids, insulin, potassium, and then treating the trigger. And this is very important. So when you start on the fluid therapy, what we do is that initially we want to give within the first hour 1 liter of normal saline, that is 0.9% sodium chloride in 1 hour. And then if corrected sodium is low, that is when you do the sodium, and remember you have to correct for it, as we saw from the other formula, because of that dilution from the hyperglycemia and hypervolemia. So if your corrected sodium is low, you want to continue 0.9 sodium chloride. But if the corrected sodium is going a bit high, that is not good. We want to give 0.5 half strength normal saline. Then we want to add dextrose, that is 5% or 10% when the glucose falls below 14 millimoles or 250 millimoles. And this is very important because if someone now goes into hypoglycemia and you're managing DKA, insulin production is going to stop. And when this stops, they're going to start ketosis again. It's like they are starving. The body is going to rely on ketones, and when they start ketosis again and have that paradoxical ketosis, it's going to make the recovery of this patient a bit harder again. Then in children, there are very, very critical differences, and this is because children easily get cerebral edema. So what we do, the rehydration is always very slow, and if we are in shock, sometimes you want to give 10 to 20 mils per kg of normal saline over 20 to 60 minutes. So we avoid boluses in children. And if they are not in shock, please do not give the large boluses of fluid. Then you want to replace the deficit, and then give their maintenance. So you want to find out how much are they lost. If you know it, then you can check the maintenance fluids using the whole liter formula. You can check that out, or you can use the 4 to 3 to 1 rule, and you find out their requirements for the next 24 to 48 hours, and that is what you will continue giving slowly. And you want to give isotonic fluids throughout in children, because most of the time they're sensitive to these changes in osmolarity. Then we move on to insulin therapy. So in adults, normally we use regular insulin, and that is going to be intravenous insulin. Normally when you have DKA, please use IV insulin and not the subcutaneous, because the dehydration and everything else makes the absorption even worse for the subcutaneous. So you want to give regular insulin at an infusion of 0.1 units per kg per hour. And we want to see that the glucose is falling by 3 to 4 millimoles per liter per hour, and that is 50 to 75 milligrams. So some people just say 50. You want to reduce by 50 milligrams per deciliter per hour, or 3 millimoles per liter per hour. When you do this, that is when you're safe. Then in children, you want to start only after you have given that initial fluid bolus. Even in adults, most of the time you might give that initial fluid bolus and give them a while you check for the potassium to see where you can start insulin. So in children, you are going to give insulin only after you have given that bolus and correcting the dehydration. And then you start insulin again if they have potassium greater than 3.5. Remember, insulin pushes potassium back into the cells. So if you give insulin and potassium is less than 3.5, this patient is going to have hypokalemia. This is going to predispose them to getting cardiac arrhythmias. Then the infusion rate in children is normally a dosage of 0.05 to 0.1, but the standard pediatric dose is going to be 0.05, and we never give a bolus in children of insulin, because in children you always want the changes to be subtle and slow. Once you drop the glucose very fast and the osmolarity of the blood changes very fast, they're going to develop cerebral edema. Then you want to continue insulin until you have a pH less than 7.3, until you have the bicarbonates greater than 15, and the anion gap has been normalized, as well as ketones less than 1 millimoles. And most of the times in resource settings, they rely on the ketones. You are going to treat until you have suppression of ketosis, until you have no ketones in urine detectable on the glucose stick. Then you have potassium management, and this is very important. So the key rule is that never start insulin until the potassium is greater than 3.5 millimoles per liter. And if potassium is greater than 5.5 millimoles, you may not need to replace, you may just need to monitor the patient. If the potassium is between 3.5 to 5.5, you want to at least add some potassium to your fluids. That is 20 to 40. You want to give 20 to 40 millimoles of potassium chloride per liter of fluid. So every liter of fluid, you want to add 20 to 40 millimoles. Then if potassium is less than 3.5, you stop insulin infusion, you replace the potassium aggressively. You want to give potassium now until at least when we have potassium greater than 3.5, and then we want to maintain it between 4 and 5, and as we give our insulin. And this is going to be how we manage the potassium. Then the monitoring, you want to do hourly glucose, because you want to see the rate at which it's falling. Remember, you want a rate of at least 50 milligrams per deciliter per hour, or at least 3 millimoles per liter per hour, not more than that. Then you want to do your electrolytes every 2 to 4 hours. That is electrolytes and venous blood gases. You want to see, is my pH improving? You want to see, is my potassium staying up there? Then you want to do an input and output chart. You want to see how much am I putting, how much am I getting out? And that will help you decide accordingly. Then you want to check the mental status of the patient, especially in pediatrics, because when they start developing cerebral edema, they're going to start deteriorating. The mental state is going to deteriorate. They're going to start becoming confused. They become drowsy. They may slip into a coma. So you have to always monitor the mental status. And then you want to check for ketone clearance. Are we still having ketones in urine? You check for that. Then you want to do continuous cardiac monitoring, because this can tell you if there are changes in potassium, all those abnormalities, potassium. Then bicarbonate is something that is worth mentioning, because some of the time you're going to see it being used, but it is not routinely used and has not found to have any outcome or benefit when it comes to the improvement in patients with DKA, unless they have specific symptoms or they having specific conditions that we're going to look at. So there's no outcome benefit, and it risks cerebral edema mostly in children, because once you give bicarbonate, you're going to correct for acidosis very fast. And once you do this, this may cause things to change very fast. It may also cause hypokalemia, because once you correct acidosis and hydrogen ions reduce intracellularly, potassium is going to go back to the intracellular compartment, and then you end up in hypokalemia. And then we can have paradoxical CNS acidosis, whereby we have formation of carbon dioxide from that bicarbonate. Then we have delayed ketosis resolution and sodium overload, because it is normally tanampure of sodium bicarbonate. So you're going to have sodium overload. So when do we really use bicarbonate? We're going to use bicarbonate when you have a pH of less than 6.9. This is a deadly pH plus hemodynamic compromise, because at this pH, the contractility of the heart is starting to get compromised. If we're having a severe hyperkalemia that requires us to shift the potassium, you may be tempted to use the sodium bicarbonate. And then if you have severe acidemia that is impairing cardiac function or vasopressor response despite fluids and insulin, mostly in pediatrics, you may consider using bicarbonate. And avoid even more strictly. Consider only pH less than 6.9 plus shock, and this should be done in the pediatric ICU when you want to give bicarbonate. So the dose and protocol, is going to differ from country to country, but most of the time it's going to be 100 millimoles of sodium bicarbonate and 400 ml of sterile water plus 20 milliequivalent of potassium chloride over 2 hours. And this is why we give potassium, because as you correct for the acidosis, hydrogen drops, potassium is going to move from the extracellular where it had gone, go back to the intracellular, and we shall have a hypokalemia. And you may need to repeat this if the pH is still less than 7, and then you want to monitor the potassium, the pH, the sodium, and the ventilation. Why it is avoided in normal management of DKA is because it has no mortality benefit. We have carbon dioxide generation, and that leads to intracellular acidosis. We have osmolarity shifts, and that risks cerebral edema. And then we have rapid potassium drop that can lead to arrhythmias. Then the other thing we can look at now is the cerebral edema. So cerebral edema is going to mostly occur in children, and warning signs include headache, a declining ECS, bradycardia, hypertension, as well as seizures. And most of the time we're going to treat this with mannitol, that is 0.5 to 1 gram per kilogram, or saline, 3% saline, that's hypertonic saline, at 5 to 10 ml per kg. Most of the time when the mannitol fails to work, we escalate and go to the normal saline. And then we want to transfer this patient to ICU, where we can do head elevation as well as slow down the rate at which we are giving these fluids. So we have a criteria for resolution of DKA. When we are managing and to know when do we stop. So if we are getting a pH greater than 7.3, we know we are heading into a good direction. If the bicarbonate goes above 15, if the anion gap closes or normalizes, that is, if it's less than 10, if we have ketones less than 1 millimole, and if the patient is clinically improved and now tolerating oral intake, they're able to eat, then we can say we have resolution of DKA. And once we start getting resolution, what we must do then is transition them from IV insulin to their subcutaneous insulin. And this must be done correctly to avoid rebound DKA. And these are the rules you should follow when you're doing that. So one, you have to make sure that we meet the following. The DKA has been resolved, that is biochemically, by the criteria I've seen above. The patient is alert and tolerating oral intake. Electrolytes are stable, especially the potassium. we have clear subcutaneous insulin plan documented. If you don't have a subcutaneous insulin plan, please, you have to make one. You have to determine the best thing you're going to give, the premier, and things like that. Then how to transition is that you're going to give the best or the long-acting insulin. That is 1 to 2 hours before you stop your IV. So you give it and you continue with the IV infusion for 1 to 2 hours because that is the time at least which it takes to kick in. Then you want to give the mealtime rapid-acting insulin when the food is given. You want to continue the IV insulin for 60 to 120 minutes. That's 1 to 2 hours after the first subcutaneous dose. Then you want to stop the IV insulin and continue the subcutaneous insulin. Then monitor the glucose 2 to 4 hourly for the next 24 hours. So we have the complications at last, the complications of DKA. We're going to have the early ones, which include cerebral edema, hypoglycemia, hypokalemia, hypophosphatemia, acute kidney injury because of the shock, acute respiratory distress syndrome because of the fluid sometimes, then shock. Then the late, we may have thromboembolism, we can have recurrent DKA and neurocognitive deficits. Then prevention, we have the sick day rules where you guide the patients, tell them what to do when they are sick, because we know this is when they need now increased insulin requirements. Home ketone monitoring where they can do it on their stop. Never stop insulin is a rule because when you do, DKA setting. Good hydration is important. Early review of vomiting. If you have a child vomiting, please do and make sure you see that they're not in DKA. Then education on pump failure. Nowadays we have the insulin pumps and most of them have an alarm that rings when the pump is blocked. Sometimes the patient may have the pump on, but the pump blocks or the IV access blocks and they don't know and they end up in DKA. Then you want to stop SGLT2 inhibitors whenever you are having an illness or the patient is going for surgery. So we have come to the end of this video and we have covered a lot about this emergency of DKA. I hope you've learned a lot and I hope you liked the video. If you did so, please to subscribe to the channel, leave a comment, leave a like and share with a friend. My name is Benjamin. Till we meet again, this is my own page.